Am I audible?
Yes, yes.
Good evening, everyone. So welcome back to our Marathwada SFM meeting. So meeting after so many days. Actually, we were thinking to meet in person after the pandemic would have been over, but you know, all the situation and everything is there. Hope it will die down and we may meet after maybe in July or August somewhere. So right now, this is our monthly meeting. We are again going to start the same every month. Hope so online till the pandemic is continuing, and then later on we may have it at various places like Latur, Nanded, and at different places like. So today we'll be starting with the cases. So it will be a case-based discussion. We are covering commonly met cases and then some uncommon cases and very rare things like. The first case will be presented by Dr. Shadab. Dr. Shadab Nasir.
Shilpa, can I say 2 words, please?
Yes, sir. Yes, sir. Sure.
Before we go into the cases. Good evening, everyone. Welcome you on behalf of SFM and SFM Marathwada. And I take this opportunity to welcome some legends who have actually joined to motivate us, though it's just our monthly meeting. But we have our, you can say our immediate past president or the backbone of SFM, Dr. Ashok Khurana, who's joined, and this is more to motivate all the young. We have Dr. TLN Praveen also, our president, who has joined, Dr. Mohit Shah, our vice president, who has joined, and there are others, office bearers also. And I think this feature coming from our headquarters, our head office, from our national office bearers, to come forward and take out their precious time and try to motivate the presenters for today's, because we realized that we were doing our quarterly meetings since the time the pandemic started, but we were missing out on our monthly meetings, which was a regular feature of SFM Marathwada. And so we are missing the Hedgewar Hall, but yes, we are in front of the computer today. But so we decided that let us continue what we were doing before. So we'll keep having our monthly meetings, and we'll of course have our quarterly meetings definitely, which would be bigger shows. But looking at the number of people, there are nearly 170 people who have joined in, and so I'm this really makes me very happy, and I think this would be a big motivation for our dynamics and joint secretary and the other office bearers of SFM Marathwada to keep giving you wonderful meetings and to keep giving opportunities to our local talent to come forward and present and showcase their work. So with this, back to you, Shilpa.
Thank you.
And Dr. Krishna Gopal has also joined in. Thank you, Dr. Krishna Gopal, for coming in.
Yeah. Thank you, Sani sir, and welcome all the office bearers, and thank you, Khurana sir, Praveen sir, and all the office bearers. With your Ashirwad, we will be starting our session. So the first case will be presented by Dr. Shadab Nasir. She is going to present a case of anencephaly with the commonly encountered problem. A bit of theoretical we will be discussing, and then some words of wisdom will be given by Sahani sir. And just a brief introduction of Shadab. She is from Aurangabad, and she has done her PG, and she passed as a PG in 2015. And she has started her own ProCare Diagnostic Center 6 months back. She is very much interested in fetal radiology, fetal medicine, and everything like that. And without much time, I request Shadab to start with the case. Over to you, Shadab. You can share your screen. You can share your screen now. Unmute yourself, Shadab.
Yeah, she has.
Yeah, ma'am. My screen is visible to all of you.
Yeah, it is. Yeah. It is. Okay. But we are not able to see.
Good evening, one and all. Yeah. First of all, I want to thank Dr. Sahani sir, Dr. Shilpa ma'am, and SFM team to giving me opportunity to speak in front of you. So let's move to the case. 30 years G2P0L0A1 woman came for anti-scan at my center. It was her first scan. She was 12 weeks, 5 days by spontaneous conception. She was non-diabetic, non-hypertensive, and euthyroid. Her marriage was non-consanguineous. There was no history of fetopathic drugs, and there was history of pregnancy with anencephaly fetus 2 years back, and she got aborted at 16 weeks for that. On ultrasound, I found this kind of CRL image. There was absent cranial bone, and outer margin of head was abnormal, and there was increased NT with absent nasal bone. On coronal image, the head appeared wider to me with sonolucent areas, as you can all see. And amniotic fluid was also not normal. It was appeared echogenic, quite milky. And on the TVS, the head appeared wider with sonolucent areas, and outer margin was appeared to me bilobed. So it was the first time I saw this kind of image. So it was Mickey Mouse sign. So all these findings took me to the final diagnosis of anencephaly. So as anencephaly is incompatible with life, patient terminated the pregnancy 3 days after the scan done. Am I audible?
Yeah.
Yeah. So
Shadab,
before going into the
just a minute, Shadab, have you stopped sharing? Your video is mute, or you can, like, we are not able to see you. We are able to hear you. We are able to see your screen, but we are not able to see you. So.
Okay, ma'am.
It's okay. No. Don't do anything.
Can I start?
Yeah.
Before going into the detail of anencephaly, we should know the classification of neural tube defects. So anencephaly comes under the open cranial defect. And to understand anencephaly, we should know the Acrania-Exencephaly-Anencephaly sequence. There are 3 phases in the development of anencephaly. First is dysrefia, or a failure of the neural groove to close in the rostrum region, that is cranioschisis. Second is exencephaly, and finally anencephaly. So it starts with the finding of acrania, that is a rare lethal congenital anomaly that is characterized by absence of calvaria. There will be complete brain tissue will be present, and skin also will present, and that's why brain is not exposed to amniotic fluid. That will be opposite in exencephaly, that the absence of the calvarium and the skin will also be absent, so it results in exposure of the brain to the amniotic fluid. Finally, anencephaly, that is the most severe form of cranial neural tube defect. So definition of anencephaly is the complete absence of the calvarium, skin, meninges, and the forebrain. For incidence, one incidence of anencephaly is like that 1 case per 1,000 live births worldwide. And for pathology, we should know that it results from a failure of closure of the antral end of the neural tube, which is expected to occur around 24 days of embryonal life. And missing parts will be prosencephalon, mesencephalon, and the rostral part of the rhombencephalon. And then we'll move to the etiology. It can be isolated or a part of malformation syndrome. And first of all, first etiology, as we all know, the folic acid deficiency, then family history, diabetes, obesity, hyperthermia, teratogenic exposure, genetic problems, and associated with other syndromes like trisomy 13, 18, or 21, or single gene disorder like Meckel-Gruber syndrome. Then we'll move to the association. We should also know the to which it can be associated. First of all, most common is an other neural tube defect like spina bifida. It is 24%. It is called as cranioraquistes, like anencephaly plus spina bifida. Others are cephalocele, congenital heart defect, cleft lip of cleft palate, spinal dysraphism, and hypoplastic or analogous folding of the ears, diaphragmatic hernia, skeletal anomalies like club feet, GIT problems like omphalocele, and in urinary tract hydronephrosis is most common. And in risk of recurrence, we should know that if one parent is affected by neural tube defect, risk of recurrence in offspring is 4.5%. If previous full sibling is affected, then risk is 4%. And if previous two siblings were affected, then risk is 10%. And among half siblings, if it is there, then risk is 0.5 to 0.8%. Then we'll move to the most important part, antenatal ultrasound. And we should know that this is the first malformation reported using TVS in a fetus at 11 weeks, 5 days. So anencephaly may be sonographically detectable as early as 11 weeks. So on ultrasound, we will find, we can find echogenic or milky amniotic fluid during early second trimester or first trimester. It is considered diagnostic for the presence of anencephaly. There can be less than expected value of CRL, or there may be polyhydramnios in 50% of cases due to impaired swallowing. Exencephaly, then ultrasound finding is exencephaly, that it is a transient malformation. It is a precursor of anencephaly. It is seen at an earlier stage, like in first trimester. There will be absent cranial vault recognized at 10 to 11 weeks, and brain is exposed to amniotic fluid. There will be preservation of face and bones of base of the skull. Ventricle and choroid plexus may be apparent during the first trimester. And this sign, Mickey Mouse sign, we can see at this stage that there will be wide fetal head with sonolucent areas due to disintegrating brain. And the outer shape of head is appeared bilobe, that is called a Mickey Mouse shaped head. You can see in the image. And we should also know the other abnormalities of the head, like foreshortened, elongated, cystic, overhanging, or irregular. These are the other abnormal appearances of the head. Then in anencephaly fetus, ultrasound finding will be, it is more easy to detect because of the severity of the malformation. And by the second and third trimester, the classical appearance is seen. There will be symmetrical, partial, or total absence of the cranial vault above the orbit. And there will be variable degree of disintegrating brain tissue may be seen. Occipital bone and brainstem cerebellum may be variably present. So on sagittal view, the profile of chin, lips, nose, like face and the orbit appear normal. In superior area of the orbital ridges, the forehead and calvarium will be obviously missing. On coronal view, absence of the cranium above the prominent orbits, and the prominent bulging eyes will appear. So it gives the frog's faces appearance like this. You can see in the image. And we should know the morphological spectrum of anencephaly. It moved from merocrania to holocrania. Merocrania is the mildest form and the holocrania is the most severe form. In merocrania, there is partial or incomplete median cranial defect with ectopia of brain. And it can be confused with cephalocele. So we should know that there will be no skin covering in ectopia brain in case of merocrania. Holocrania, it is most severe form, and most or all the calvarium is missing at the level of foramen magnum in case of holocrania. And the most important topic, differential diagnosis. As we should know, we have to know the differential diagnosis in each and every case. So there are three DDs are there. That is the amniotic band syndrome, that is fetal decapitation, and microhydranencephaly. In amniotic band syndrome, obviously there will be amniotic band, and asymmetric absence of the calvarium will be there. And most important thing, it is non-recurring cause. So we can counsel the patient that it will not recur next time. Mostly a rare cause is the absent fetal cranium is fetal decapitation in utero and microhydranencephaly, in which the cranium will be present, only the head circumference will be reduced, or there will be a hydranencephaly will be there. So prognosis, not surprisingly, it is incompatible with life. It is a lethal condition. It is more common in female. 75% are stillborn. Most die within first 48 hours, and remaining die within first week of life. For prevention, we should know that neural tube closes 28 to 32 weeks after baby is conceived. This is before many women are aware that are pregnant. So normal brain and spinal cord development may be affected during these first 3 to 8 weeks of pregnancy. So it is recommended that all the women of childbearing age take a multivitamin that has folic acid, and getting the vitamin before a woman knows she is pregnant and early in pregnancy is most important. So folic acid therapy may reduce the risk. Folic acid can help prevent 50 to 70% of the cases of neural tube defects. Thank you. Thank you all, and I want to especially thank Dr. Anirudh Kulkarni sir and Dr. Sujit Konkar sir for guiding me. Hello? Hello,
Yeah,
am I
yeah,
audible?
Shubha. Now you
Yeah.
unshare your screen.
Yeah.
Now Sujit
Stop
Konkar will
sharing?
take over. Yeah, stop.
Yeah.
Sujit, over to you. Sujit, you can take over. You have to unmute yourself, Sujit.
He is unmuted, but we can't listen to him.
We are not able to hear him.
Sujit, can you hear us?
Can I hear now?
Yeah.
For a nice presentation. The first one is the earliest accepted. Professor Simon Migger, the great, he has given a very excellent talk on this in ISOAG World Congress in 2018 at Singapore. So he told that the earliest gestation at which anencephaly can be suspected can be as early as 7 to 8 weeks. He has given two important clues. First one is hyperechogenic amniotic fluid in the sac, in contrast to the perfectly black coelomic cavity. This is more evident in cases of twins because we have comparison for the both things. This hyperechogenic amniotic fluid is because of disintegration of the brain tissue. This was one clue. Second clue is that he emphasized that you should make a habit of identifying the cranial end and caudal end with the help of rhonchocephalic vesicle and cord insertion, even in small fetuses. So whenever you see tiny cranial end, you have to suspect anencephaly. So these two clues are very, very important. Second thing is that you must measure or make a habit of measuring biparietal diameter and head circumference from 11 weeks onwards from your routine NT scan. In this way, you will never miss anencephaly. The detection rate is almost 100%. So there is one question for Dr. Alka. What are the genetic aspects of anencephaly? For example, in this patient have had history of anencephaly in her first pregnancy, which was terminated at around 16 weeks. And there was recurrence in second pregnancy. So whether invasive testing need to be offered in these cases?
Yeah. Alka, 1 second. Before you answer, let me introduce Dr. Alka Ekbote. If you watch, Tarak Mehta, they say now that Gokuldaची एकमेव तसं मराठवाड्याची एकमेव जेनेटिस्ट. She's and she is very good with her job, and every time Khurana sir says that yes, like we are fortunate, we can bank on whenever we want, we have Dr. Ratnapuri to call up, and so same way for us in whenever we have doubts, whenever we want something more to be added, then there is only one contact we have as far as genetics is concerned, and that's Dr. Alka Ekbote. You can continue, Alka. Sorry for interrupting.
Thank you for your kind words, sir. And first of all, Shadab has presented a very nice case. Obviously, it is her first, we can see, but she's going to be better. Yeah, Sujit, the question is very valid that there are two kids who were affected with the anencephaly. The first,
I think.
Can you increase your volume?
Yeah.
Volume is low. Yes.
Your volume is less.
Yeah. So am I audible now?
Yeah.
Yeah.
I think you can directly talk to the laptop if you have a laptop. That becomes much more.
Yeah. But I prefer this.
Okay.
So yes, if there are two babies who are affected with anencephaly, there are two things that we have.
Alka, we are not able to hear you properly.
Okay. Can you hear me now?
Yeah.
It's
Yeah.
better now.
Yeah. Okay. So, like I said, okay, there are two things when it comes to anencephaly in this particular case. One is that one part of the history is that there are two children affected. Obviously, the previous fetus was also affected. There are two considerations. One is whether this is an autosomal recessive suspected case or whether it's an autosomal dominant. Now, we may wonder how it can be an autosomal dominant condition. In that case, the parents would also be affected. But the autosomal dominant condition, it can still be, and the parents can carry the neural tube defect in a very small, in a very minor condition. So in such a cases where we see two fetuses affected with anencephaly, we must do the parental X-rays or parental X-ray of the spine to know, if possible, CT, otherwise X-ray is good, to know whether one of them is carrying one hemivertebra or so that would solve the condition. The second thing is whether it's an autosomal recessive condition. Anencephaly as an autosomal recessive condition does exist. Most of these are related to one single gene called PRIM36, which is now proven to be one of the main cause of anencephaly. And in such a case, we would like to do a genetic testing if possible. But as the purpose of the genetic testing should be to be able to offer a prenatal testing, and that we can anyway do with the sonography. So in most cases of anencephaly, we do not really do a genetic invasive testing, but for the sake of academics and to know the cause, we should do it. The third consideration is the genetic folic acid deficiency, that is the defect in the folate pathway. Now, that is very important because it can have a importance in the way that the treatment can be altered. For example, the most commonly used molecule to treat or to prevent is a folic acid that we give to all pregnant women before the pregnancy. And in cases you have a defect in the folic acid metabolism, folic acid is not going to be effective. And in that case, that genetic testing actually would have an implication. So we may need to do a folinic acid or any other substance that is required in such a case. The fourth consideration, which is why the folic acid deficiency should occur in the absence of a genetic causes. Now, there are so many other conditions. Say, for example, parents being thalassemia carriers, parents who have had a surgery of the gastric, somebody having a celiac disease. And all these conditions can lead to the folic acid chronic deficiency and require more doses of folic acid to be given to the parents or to the mother, and for prevention of the disease in the next pregnancy. So all these things could lead to recurrence of anencephaly in the fetus, and some of them are genetic, others may not be.
Okay, thank you, Dr. Alka. There is one question for Sahani sir.
Yeah.
How to define polyhydramnios in first trimester? This is from chat box.
Yeah, you know, it's a subjective assessment. And if it's a little more earlier, and then if you find that the sac appears a little larger than the CRL, but otherwise in the 11 to 14 weeks, it is primarily a subjective assessment.
Thank you, sir. One more question.
Praveen,
yes, sir.
Praveen sir wants to add to that.
Yeah, yes, sir.
No, not adding. I just wanted to ask Dr. Alka about the NTFHR gene, which is responsible for folic acid regulation. Can she give us a little more light on that? Because that's always a little tricky situation. Dr. Alka.
Yes, sir. Yes, sir. There are now there's a common polymorphism in the MHTFR gene, which is responsible for the thrombosis. We know, like we check this same thing, molecule for the.
We are not able to hear you, Alka.
Yeah,
I'm sorry.
Speak loudly. Yeah.
Okay, so they are. Am I audible now, sir?
Yeah, yes. With this picture.
And so the MHTFR gene, which is autosomal dominant gene, okay, it has polymorphisms. One of the disease in which it is implicated is the thrombophilia. The thrombophilia, we check the common polymorphism called 619 place, which is the most common polymorphism found in the population, which is around in 50% of our, if we check ourselves, we may have that positive. But the mutations which are responsible for the folic acid deficiency are not the ones which are responsible for the thrombophilia profile. So there are other mutation in other domain of the MHTFR that we need to check in cases where the MHTFR is suspected. And commonly available MHTFR test does not include it. So they have to do a whole gene sequencing or probably a folic acid pathway defect, where they will cover both MHTFR, they will cover MTR gene, they will also cover the 3 other genes which are in the same pathway, and that will complete folic acid pathway defect loop for us.
Thank you. Thank you. Very nice.
Thank you.
Thank you, Dr. Alka. One last question to Bimal Sahni, sir. Is there any role of 3D imaging in cases of anencephaly?
Is there any
Role of 3D imaging,
Yes.
dimensional imaging?
You don't need it to make a diagnosis, but yes, that gives you especially if you're doing a little early on, it does add up to your diagnosis. But otherwise, if you have a 3D and you can perform it transvaginally, yes, it has a role there. But as far as diagnosis, there was a time when making a diagnosis of anencephaly also used to make a big thing for us, right? At the time when this thing. Nowadays, if you miss an anencephaly, that becomes a news. So as far as anencephaly is concerned, the times have changed. But if you have 3D, yes, and especially differentiating between these forms and all, it does help you.
Thank you, sir. Are there any additional inputs about this case?
Yeah, there are 3 points that I want to make. One is we've been talking about folic acid. Now, it's very important when folic acid should be started. We normally do start folic acid after the patient has been diagnosed, a patient has got a confirmed pregnancy. But folic acid should be started pre-conceptional. That is an important message. That is because, see, India is one country with a very, very high amount of neural tube defects. So I think that is one very strong message that I would like to give, is that because it is such a cheap medicine, it's something which is very easily available at a very, very low cost, and hence that kind of an awareness about folic acid needs to be created so that people, whenever they decide or they are planning a pregnancy, so that is the time they should start off with folic acid. Secondly, or one of my teachers always used to say that people used to say, you call it a marriage pill, but then he said we should start calling it as an engagement pill, where if somebody gives you a call and says, doctor, my daughter has got engaged. So say congratulations later. Before that, tell them, but have you started her on folic acid? Start her on folic acid. So that is the kind of awareness and message that we want to give about it, because we have a huge chunk of neural tube defects in our country. Another point is there was a time when we were learning, there was one more finding that people used to talk of, is that jerky movements. Because of loss of cortical control, there used to be, okay, but now that we are practically picking this up at the 11 to 14 weeks itself, we don't really get to see that. And then there is also an entity called Acrania. For a long time, Acrania and Acrania were always taken as synonyms, but there is a difference between the two. Now, because Acrania is lethal, Acrania is a precursor to your exencephaly and the anencephaly, whereas Acrania, of course, where the cranium is absent, but you have the scalp and the skin. Now there are some at least 3 to 4 cases which were documented, which are live. Those babies, they have certain neuro problems, but they are live. Of course, only thing is they just they don't have a calvarium, they have a scalp, the skin over their head, and hence they are very, very prone to any little, you know, we always like to do a tuple on people's head, but you can't do it on their head because that is going to immediately cause problems. So that is one condition which again becomes very difficult to differentiate. A lot of times you may feel that it is more of you know, like hypomineralization which is there. So these are all differential diagnoses for that. But one point is that you would find that the brain structure is completely present. The brain structure is completely present. You are able to see the ventricles. Yes, it is associated, it can be associated with ventriculomegaly, it can be associated with holoprosencephaly. There are cases documented with that. But then you have a complete brain present. Whereas in acrania is covered by a very thin membrane, and that is the reason, because of continuous pressure from the placenta and the surrounding structures. Eventually, it goes into an exencephaly, and once once you have an exencephaly, by the time it comes into the second trimester, 16-18 weeks, you have the classical anencephaly, where there is hardly any brain tissue which is present there. So that is one more point which I wanted. There is also a condition called hypocalvaria. In hypocalvaria, again, you have the flat bones which are not absent, they are present, but they are hypoplastic. And so these are the babies who would have you know, very large sutures or very large frontanelle. So because we are talking on this, I thought let us just complete this you know, this whole sequence. So this is a little different from the Acrania-Exencephaly-Anencephaly sequence.
Can I add a thing?
Yes, sir.
Yeah. So somebody asked whether amniocentesis could be indicated in every case of NTD. And I would say that it's not necessarily indicated if you could counsel the parents beforehand to do the genetic testing on the fetus, at least karyotype and DNA banking. And if autopsy is possible to look for other anomalies, because we may see anencephaly, and in that case, we may not be seeing anything else.
Yeah. I will ask Khurana sir the same question which Sujit asked me, that how does 3D help, sir?
Yeah, so primarily I use 3D because I get very stuck sometimes with a very obese patient. And then my transvaginal doesn't help me because the head is high up and the fetus refuses to come down. In that case, I do a 3D sweep and I get a much better delineation because the contrast differentiation is much better. So that's why I just routinely use it for all the obese patients just to be sure. That's where it really helps. A transabdominal 3D, transvaginal, if we get a good view, then we're very happy because the fetus is transverse, we get a good view. But our problem is the huge patient, the 95 kilos, the 105 kilos PCO, which have a much higher incidence of neural tube defects and anencephaly. Then I just do a 3D sweep at 12 weeks and make a diagnosis.
Sir, another question to you is because you do a lot of early pregnancy scans also. Unfortunately, I don't get to do them. But, you know, so if you suspect at around 9 weeks, would you, you know, there are quite a lot of findings which are quite classical now, but would you straight away ask for, give them an option of termination, or would you still want that we need to wait till about 11 to 12 weeks before we give a final diagnosis?
Yes. So I always like to wait because I want to make sure whether it's an isolated anencephaly or whether it's a syndromic anencephaly. And the syndromic anencephaly, we will not be able to identify at 9 weeks. So then I call them back at 12, not at 11, and make sure it's not a syndromic anencephaly. Because that could make the difference in the entire diagnosis.
Thank you, sir. Because that's a very, you know, because it also depends at your level of expertise. But, you know, at times, if you are feeling that you're down, I would say it is always better rather than jumping on a conclusion at about 8 weeks. And yes, you can put a suspicion. You can say that it is always better you call them at around 11 to 12 weeks, confirm it, and then only, you know, give it as acrania or exencephaly or anencephaly, whatever, because usually at that time what you see is more of an acrania rather than classical anencephaly that you make out there. Back to you, Sujit.
Okay, thank you, sir. So this was everything about our first case. Now we will move